you look at the cardiac arrest data that we've had, if at 2012 out-of-hospital cardiac arrest data, we had 300,000 out-of-hospital cardiac arrests. 53% of those survived to be transported, so it works out about 159,000. Resuscitation was attempted in about 100,000 of those patients, which is about 25% overall. 40,000 patients survived to hospital admission, which is only 10% of all cardiac arrests. And the overall survival of discharge rates for VFib arrest is only 8%. So the numbers are pretty dismal. So as we're doing things the old-fashioned way, AHA way, our numbers aren't really good. So we looked at different ways we can reinvent ourselves and find better ways to improve cardiac arrest outcome. The Scandinavian Journal of Trauma and Resuscitation in 2012 in emergency medicine also showed, based on the rhythm you have, the out-of-hospital survival to discharge rates are vary as well. If it's PEA, the survival to discharge was 5%, Asystole 2%, and VFib 19%. So depending on your rhythm, the chance of survival are going to be significantly different. So if we can be as aggressive as we can, as early as we can, maybe we can improve our numbers. There's a lot of talk about medications in cardiac arrest and how valuable are they. So if we look at the literature, people think or have questions whether the medications in cardiac arrest are effective or not. The data basically shows there's no increase of cardiac arrest survival to discharge based on the medications that we provide. Atropine has been shown to increase mortality in PEA. 2010 guidelines was removed in PEA. Worsens neurologic outcome with no value in asystole. Epinephrine improves ROSC rates for non-shockable rhythms, does not improve survival to discharge outcomes. However, some early administration may be of benefit to patients. So what is ROSC? ROSC basically is restoration of spontaneous perfusing rhythm. You basically have a normal EKG and vital signs, but this is only our intermediate goal in cardiac resuscitation. We are coding the brain, which a lot of us seem to forget. Two things will tell you how well your ROSC is going to be determined: if your initial end-tidal CO2 is maintained greater than 10, and there's an absence or lack of falling of end-tidal CO2 greater than 25% from the initial baseline. Both of these signs together are associated with ROSC and out-of-hospital cardiac arrest. When you're doing resuscitation out-of-hospital cardiac arrest, you want to make sure that you're addressing MAP. Why is MAP so important? MAP is the perfusion pressure of the body organs during one arterial cycle pressure. A normal MAP is between 70 and 110. If your MAP falls below 70, the end organs will not be perfused and ischemia and organ damage will occur. So you need to have a MAP of at least 60 just to perfuse the organs. Unless your MAP is 65 or higher, you're not perfusing the brain. So it comes down to, remember, we're still coding the brain. If we're not producing a MAP of 65 after a ROSC, you're causing anoxic brain injury or brain injury in general. If you look at cardiac arrest and ventricular fibrillation, the most common cause of ventricular fibrillation is acute MI. 60% of these VFib arrests are witnessed. 80% occur at home. 71% of all VFib ROSC patients have some form of coronary artery disease, and 50% of all VFib ROSC patients have acute coronary occlusion. So it's very important that there's things we can learn from this. If we get involved in the community early, we can make the community aware, being that VFib arrests are witnessed 60% of the time. And if we have a plan at home, we can increase survival as well. The 2013 STEMI Guidelines came out, and they mentioned a couple of important things. Therapeutic hypothermia should be started immediately for all comatose, STEMI, and out-of-hospital cardiac arrests due to VFib or VTAC. Immediate PCI is indicated for all STEMI arrest patients, including those receiving therapeutic hypothermia. And at the Eagles conference this weekend, they had mentioned that the fact that you have a STEMI that resolves en route to the hospital does not mean the person's not in STEMI anymore because their EKG is normal at baseline. These people should all be taken to cath lab for immediate PCI. So if you want to break down ventricular fibrillation, there's 3 phases to look at. Phase 1 is the electrical phase. Basically, it's 0 to 5 minutes. the myocardium has neither used up all its energy stores or undergone serious cellular damage. So immediate defibrillation is great for these witnessed immediate ventricular fibrillation patients. And as the myocardium is able to respond to these electrical defibrillation and generate a perfusing rhythm, the chances of resuscitation are very successful at a very early point. And that's the reason people have ICDs and AEDs have been very successful, because the early defibrillation can make a big difference in survival. And as you can see, people with all CPR, CPR only, and AED and shock have the much highest survival rates. Phase 2 is a circulatory phase. It occurs about 5 to 10 minutes after cardiac arrest, and these are patients with VFib sustained for more than 5 minutes. For these people, 2 minutes of good CPR prior to defibrillation is needed, because defibrillation without doing CPR first is much more likely to be able to perfuse and fill the coronary arteries up and prevent the rhythm going to asystole or PEA. So basically the mnemonic is basically prime the pump. So you do 2 minutes of CPR before you defibrillate phase 2 patients. And as you can see, as the resuscitation goes, the perfusion pressures, coronary perfusion pressures increase, and these people respond to defibrillation much better. Phase 3 is a metabolic phase. This is the usual phase that most patients present to the emergency department. 10 minutes or more after the arrest is the least understood phase. At this time, toxins begin to circulate through the body, resulting in systemic cell death. And really only therapeutic hypothermia has the ability to slow down cell death. And actually a lot of medications at this point, especially epi, this late into the game, can make things worse. And realize for every 1 minute delay in defibrillation, you lower your cardiac arrest survival rate by 10%. And this graph shows that as every minute drops, the chance of cardiac arrest survival from ventricular fibrillation drops too, by 10%. Recurrent ventricular fibrillation. This is an interesting thing. This basically is ventricular fibrillation that results and recurs more than five seconds after initial successful defibrillation. The longer the duration of the ventricular fibrillation, the higher the defibrillation threshold becomes. So it becomes much harder to basically defibrillate a patient because of A, prolonged cardiac arrest ischemia, increased cell death, increased lactic acidosis from the anaerobic metabolism, and number 3, electrophysiological deterioration of the heart. So it's just not as responsive to electricity as it would be earlier in the resuscitation. Shock-resistant ventricular fibrillation. This is a very unusual phenomenon too. This is basically ventricular fibrillation that persists after 3 failed defibrillation attempts. 20% of all cardiac arrests are shock-resistant. Currently, the survival rate is 5%, so 95% of these patients will die. They've shown that amiodarone and vasopressin is safe and beneficial. And successful defibrillation is dependent on the amount of current that's traveling through the heart at that initial time. This is based on the formula of Ohm's law, and this is how double sequential defibrillation is of benefit to shock-resistant VFib patients. And as you see, Ohm's law is electrical current and equals voltage over resistance. So if we want to increase or maximize our electrical current, we need to increase our voltage, because the resistance or impedance of each patient's body is not going to vary significantly. So we're talking about resuscitation, not resurrection. So people have the ability to get them back. The University of Arizona changed how we thought about cardiac arrest care in 2009. They reevaluated our traditional approach to cardiac arrest care, which was basically the ABC mantra. What they looked at survival from cardiac arrest, which was really low following 2005 recommendations for CPR and out-of-hospital cardiac arrest. In 2005, they reviewed the out-of-hospital cardiac arrest in Los Angeles. Neurologically intact survival at discharge was 1.4%. So basically, between 2005 and 2010, cardiac life support, CPR, had put an undue emphasis on airway for respiratory arrest and not concentrating on your heart for cardiac arrest. So what they did is evaluate the whole process and re-examine things. Did some trials, and these trials were as follows. They also found that the bystander performed CPR less than 30% of the time. And there were multiple reasons they found why bystanders were not interested in doing CPR. First of all, they were afraid of causing harm. breaking ribs, basically afraid of contracting infectious disease. The task of doing CPR seemed overwhelming. Most people, unlike what we do, panic in these kind of situations. So we're able to understand this where the regular layperson can't. And people also didn't want to do mouth-to-mouth resuscitation. So a lot of the reasons why people didn't want to do bystander CPR, which also helps survival rates. So they looked at the whole concept of CPR again. They wanted to involve bystander CPR. And they did a study, and they found that favorable neurologic survival rates with patients who received chest compressions and were given mouth-to-mouth breathing was 10.2%. Patients surviving with a favorable neurologic outcome was 22% if bystanders administered chest compressions without mouth-to-mouth. Survival improved when bystanders were coached by the dispatcher to do chest compressions only during CCR. So the survival of discharge was twice as high if they did not do any airway involvement, no mouth-to-mouth. And these are the results they found. If they compare the CPR, which was standard before 2010, to CCR, which is circulatory, airway, and breathing, survival rates were 19.6 to 47.2. Survivors with good neurologic outcome was 77 to 83, which basically equal to 15.2% survival of discharge versus 39.3 when they just did continuous cardiac compressions. So their mantra was push hard, push fast, and that's what saves lives. So what is CCR? CCR basically is a continuous chest compression where airway management and cardiac arrest is a much lower priority. Basically, good continuous compressions, early epi were the most important intervention, especially when VFib was present. And patients who survived cardiac arrest should then be treated with early PCI and therapeutic hypothermia. 2010, The Lancet did an article on chest compressions, only CPR. They proved that chest compressions only method improved survival rates over standard CPR done by Dr. Nagel as the principal investigator. They did a meta-analysis on 3 studies comparing more than 3,700 cardiac arrest patients. And this is what they found. And they compared standard CPR to chest compression only CPR. Of all the people studied, 5% survived if no CPR was performed. 6% if the regular CPR, ABC, 30 compressions to 2 breaths were done. 11% survived if bystanders continued chest compressions only and did not stop for any mouth-to-mouth breaths until EMS arrived. So the thinking is, why would that be the case, that mouth-to-mouth would lower your chance of resuscitation? This comes to the point of CPR fraction in the Annals of Emergency Medicine. CPR fraction is the percentage of time that chest compressions are being provided during a cardiac resuscitation. The goal should be 80 to 90% of the time your hand should be on a chest, but you must pause for rhythm checks as you see changes in internal CO2, patient visual resuscitation, and obviously 2 minutes for rhythm checks, because otherwise you will be doing compressions forever. Coronary perfusion pressure is the determinant of successful cardiac resuscitation, ROSC. And we must maintain a 15 millimeter mercury coronary perfusion pressure for this to be successful. And as you can see on this graph, with the 24-hour survivors had much higher coronary perfusion pressures than people who did not. So we look at compression rates and cardiac outcomes. Studies were done in the journal Circulation that showed the optimal rate of cardiac chest compression to be 120 a minute. As CPR increases depth of compressions, there's a decrease in cardiac output. So basically, a 7% decline in the depth of compressions at 2 minutes. So there's provider fatigue. They say about 3 minutes. I think these are all big, burly, strong firefighters in the hospital, in the back of an ambulance. Probably 1 to 2 minutes is probably optimal depth of compressions that we're going to provide. The optimal depth was 2 inches, and there was no increase of survival if there was more than 2-inch depth of compression. And if you look at this graph, from the journal Circulation, it shows that the optimal survival rates were occurred when the chest compression rate was 120. What about interrupting chest compressions? How important is that? For every 1 second pause in compression results in a 1% reduction of the chance of obtaining a ROSC. And it takes 10 compressions before you begin to perfuse the coronary arteries to 15 millimeters of mercury, which you need for survival. And it takes 30 seconds to begin to perfuse the brain. So then, what would be the best way we would deal with airway management? And as you see, when you do chest compressions, the perfusion pressures in the coronary arteries increase. As you stop compressions for ventilations, they drop drastically to 0. So CPR interruptions, perishock pause, journal Circulation 2011. The question was, does the length of perishock pause influence survival? And perishock pauses are pauses in chest compressions before and after a defibrillation is administered. They studied 815 VFib and VTAC patients from the ROC data, 2,300 shock studies. Optimal pause times were found to be less than 20 seconds. Pauses greater than 20 seconds increase mortality. So the take-home message was the longer the perishock and the pre-shock pauses were, they were associated with decreased survival to hospital discharge. Now, a lot of people have mechanical CPR. A lot of people can't afford it because it's expensive. Is it of any real value? The data has shown there was no definitive data supporting or refuting the use of CPR, mechanical CPR devices. However, it allows healthcare providers to concentrate on the patient without having to worry about compressions, which, as we know, as we fatigue, the depth gets worse, the compressions get worse, perfusion will be worse. But it does have an added safety for EMS providers for prolonged transport times. People who live in rural areas will have like 10 to 20 minute drives to the hospital. It'll be impossible to provide good quality CPR for people with 10-minute drives, 20-minute drives safely. And this eliminates the risk of injuries with people doing compressions going down the road at 70 miles an hour. And most importantly is continuous, consistent chest compressions. So what people do not need chest compression only CPR? Your trauma patients, your drowning patients, and pediatrics. These are people who you do not want to be doing continuous chest compressions because airway is of optimal importance of these patients as well. So intubation or not intubation? The controversies occur right now existing. What's the optimal airway management for cardiac arrest patients? Which airway is the best? End-tidal, supraglottic, bag valve, non-rebreather, nasal cannula. What device provides the best chance of survival to neurologic discharge and why? And when you're working in areas, especially rural, when you don't have all the manpower that you could in bigger areas, how would a single medic do optimal cardiac arrest care in the back of an ambulance by himself? So the theory of apneic oxygenation was brought in. What that is, it basically extends a safe apneic period beyond which good saturations can be achieved by pre-oxygenation. The theory is that alveoli will continue to take up oxygen even with diaphragmatic movements or lung expansion. In healthy patients, under ideal circumstances, a PaO2 can be maintained at greater than 100 for up to 100 minutes without a single breath. The lack of ventilation will eventually cause marked hypercapnia because the cells are continuing to metabolize and their byproduct is going to be carbon dioxide, which accumulation will be the limiting factor resulting in respiratory acidosis. So this is the theory. Apneic oxygenation using nasal cannula was performed by Dr. Richard Leviathan, who is the professor of emergency medicine at Jefferson Medical College. He found that desaturation to below 70% FiO2 puts patients at risk for dysrhythmias, hemodynamic decompression, and hypoxic brain injury and death. Oxygen was absorbed from the patient's alveoli by pulmonary blood flow gradient from an area of high to low. Non-rebreather mask set at 15 liters a minute, along with nasal cannulas, have had normal ventilation patterns capable of delivering near 90% FiO2. And this apnea time being increased will maintain with the addition of the nasal cannula where you can use a bag valve or non-rebreather during this time that you want to delay intratracheal placement. So in 2013, the JAMA article came out where they studied the association of pre-hospital advanced airway management on neurologic outcomes in patients with out-of-hospital cardiac arrest. They had a sample size of 650,000 patients in Japan from 2005 to 2010. And their findings were significant. Patients who received just a bag valve mask ventilation were 57% of the population in cardiac arrest. People who had endotracheal intubation was 6%, and supraglottic airways were 37%. The conclusion of the article was that the rate of favorable neurologic outcome using advanced airway management, i.e. supraglottic airways and endotracheal intubation, was 1.1%. The rate of favorable neurologic outcome with bag valve mask management only was 2.9%. So the odds of neurologically favorable survival were significantly lower both for endotracheal intubation and for supraglottic airways. The Journal of Academic Emergency Medicine 2011 did a retrospective study from 2006 to 2008 done at Mecklenburg EMS system. They analyzed 1,100 cardiac arrests and examined the impact of pre-hospital endotracheal intubation. They compared ROSC rates, and they also compared survival to discharge for out-of-hospital cardiac arrest. Patients with no endotracheal intubation attempts were 2.3 times more likely to obtain ROSC compared to individuals with one successful endotracheal intubation attempt. Patients with no endotracheal intubation attempts were 5.5 times more likely to be discharged home than those with one successful endotracheal intubation attempt. Thus, the finding was increased endotracheal intubation attempts are correlating directly with the negative outcomes for sudden cardiac arrest. 2010, Annals of Emergency Medicine, Cardiac Arrest Resuscitation, looked at other airway options used by EMS personnel other than endotracheal intubation for out-of-hospital cardiac arrest. It was a 3-year study, 1,000 patients. Basically, these patients got 3 rounds of CPR, about 8 minutes before endotracheal intubation. They had bag valve mask, or they had a non-rebreather mask with continuous flow oxygen. So you had forced air versus passive air. What were the study results? Neurologically intact survival after witness cardiac arrest with shock, with a shockable heart rhythm, were as follows. If you received a bag valve mask, your survival of discharge was 25.8%. If you received passive O2 by non-rebreather, it was 38.2%. The findings show that during resuscitation, patients with cardiac arrest should receive passive ventilation. 2009 article on CCR by Garza and al. Compared 1,100 patients receiving CPR versus CCR, comparing Utstein pre-hospital VFib adults. So no intubation for 3 cycles. Survival of discharge increased from 22 to 44%. 88% of these survivors were discharged home neurologically intact. 2009 article on Annals of Emergency Medicine studies CCR with witnessed arrests with initial shockable rhythm. Patients were given either early IV epi with non-rebreather, or until ROSC was obtained, or 5 cycles of compressions and shocks for a total of 12 minutes. This study showed the overall survival increased from 20 to 47%. Neurologic survival of discharge increased from 15 to 39%. So it seems like the non-rebreather mask seems to have a benefit for cardiac arrests. And it's a good early airway management tool. Provides a FiO2 about 65 to 80%. This is basically the gas participating in air exchange. And patients with difficulty breathing were provided O2 enriched atmospheric oxygen. Natural air is 20.9 O2 and 0.21. So non-rebreather shown to provide a buffer for up to 8 minutes before saturation drops below 90%. So you have bought yourself at least 8 to 10 minutes of time at 90% while you can concentrate on things that will make a difference in cardiac arrest. So passive flow versus forced ventilation, what's the difference? If you look at passive airway flow, it lowers intrathoracic pressure, no hyperventilation, uses oxygen in the lungs and circulates it in the body. With bag valve mask, you raise intrathoracic pressure, hyperventilation increases with side effects, and there's less coronary perfusion pressure. So bottom line, compression-only CPR. Compression-only CPR uses the O2 in the lungs, which is carried throughout the body. Ventricular fibrillation patients do not need immediate O2. Asystole versus PEA with long downtimes will need O2, but it's a different animal, and we'll go into that shortly. And oxygenate and ventilate is more important than intubation. So perfusion is more important than intubation, and the goal is the elimination of anaerobic byproducts of CO2. Now we do want to, when we do intubate patients, there are things we have to be concerned about as well. Because once we intubate, people get excited and they start hyperventilating patients. Why is this a bad thing? Well, when you hyperventilate post-cardiac arrest patients that are intubated, you cause systemic hypotension, you cause myocardial depression, you increase O2 free radicals, you increase intrathoracic pressure, decrease coronary perfusion pressure, you decrease cerebral perfusion pressures, and overall you lower your survival rates. When you intubate, and if you intubate a cardiac arrest patient, you want to have their ventilation rates at 1 every 10 seconds for a successfully endotracheal intubated patient. Now, a big part of endotracheal intubation and cardiac arrest care is end-tidal CO2. This is an invaluable tool for pre-hospital cardiac arrest. It reflects cellular production and transport of CO2, shows tissue's metabolic rate, the ventilation rate, and blood flow and circulation. End-tidal CO2 correlates directly with cardiac arrest output. Reflects the quality of CPR, instant analysis of ongoing cellular metabolism. And what I'm saying is that when you get a pulse back, your end-tidal CO2 will skyrocket. And then as you regulate, your end-tidal CO2 will drop. As long as you're maintaining it, you're doing good CPR. When you notice your end-tidal CO2 drop, your CPR rates might need to increase, or there is rescuer fatigue, so it gives you a chance to change out the rescuer. Normal rates are between 35 and 45. If you have a prolonged end-tidal CO2 less than 10, that's sustained, it's associated with clinical death. Now, impedance threshold devices. This was studied in New England Journal of Medicine. Basically, they're used in theory to enhance venous return and cardiac output during CPR by attempting to lower intrathoracic pressure, which improves your cardiac filling and diastole. This journal study basically showed it did not improve survival with satisfactory function in out-of-hospital cardiac arrest patients, and showed basically had no value. We also decided to cool patients as well, and this is therapeutic hypothermia, and we do this for a few reasons. First of all, we want to give our providers more time to be able to successfully resuscitate patients, slow cellular metabolism, and the cellular metabolism drops 6% for every 1 degree drop in temperature, minimize cellular toxin levels and its effect, and also minimizes cellular reperfusion injuries. So we thought, let's change how we approach cardiac arrest care. Let me give a little detail on Polk County. It's about 2,000 square miles, population of 630,000 patients. We ran 99,000 calls we were called on 99,000 calls, ran 74,000. 5 hospitals, it's a large area, a lot of rural areas too. Some transport times to the nearest hospital could be 20 minutes. Some hospital transport times are 2 minutes. 32 ambulances, integrated 911 priority dispatch, and about 1,000 providers. So what was the goal of our cardiac arrest protocol? We want to emphasize, as all the studies have shown, continuous non-interrupted chest compressions. 2 minutes of high-quality CPR between medications. We found that early bystander CPR does improve survival at discharge. Our airways were going to be, we have the iGel, a non-rebreather, bag valve mask, or nasal cannula with an OPA. We decided to have no endotracheal intubations for cardiac arrest patients, humeral IOs, no IVs, nasal capnography with end-tidal CO2 monitoring. We initiate therapeutic hypothermia in the field with cold saline at 4 cc's prior to ROSC. We also apply one ice pack to the neck and back for neck and head for carotid cooling. Studies just came out, hasn't been published yet, but this was demonstrated in the Eagles, that cooling with large volumes of cold fluid post-resuscitation, post-ROSC, is highly not recommended. So if you're waiting to cool them after you get a pulse back, it's the wrong thing to do. So in our protocol, we have unfortunately a shortage of vasopressin, so we're just going by epi right now. We approach cardiac arrest in different ways. Each cardiac arrest is different, so we want to approach it differently. Witnessed arrest, immediate defibrillation. Apply a non-rebreather with nasal cannula or bag valve mask for 10 minutes. Continuous uninterrupted chest compressions for 2-minute intervals with checks every 2 minutes for vital signs and rhythm changes. 5 rounds of IO medications in total. We have the Phillips monitor. We defibrillate at 200 joules maximum 3 times. If after 3 failed attempts at 200, we will double sequential defibrillation with 400 joules. And the iGel is placed after 5 cycles. In unwitnessed arrest, we immediately place an iGel, continuous uninterrupted compressions for 2 minutes, check for vital signs and defibrillation. 1 round of interosseous medications, defibrillation 200 joules as we said, and double sequential after that. And as you can see, if you look at the cardiac rhythm with no treatment, you see what happens in myocardium, delayed defibrillation, it takes a while for the rhythm to get back, and if you have early access, early CPR, early defibrillation, early ACLS, chance of getting a pulse and a good outcome are much higher. PEA and asystole, we approached that similarly, and we kind of did a more of a thought view on it. Immediate IGL, because airway is important because hypoxia is one of the H's and T's for PEA. IO-epi, obviously in both arrhythmias. Continuous compressions at 120 a minute, and we have a PEA cocktail, which is basically 1 interosseous amp of bicarb, 1 amp of D50, assuming that the AccuCheck is less than 60, 500 cc saline bolus, and Narcan 2-gram IV. What that does is, if you look at the PEA protocols, it will treat your hyperkalemia, hypoxia, you'll keep them warm with hypothermia, the bicarb treats your acidosis, the saline treats your hypovolemia, your hypoglycemia is being addressed. We can't, from the pre-hospital field, fix tamponade. We could tension pneumothorax, pulmonary embolism, and MI we hopefully recognize. Toxins can be reversed with Narcan and bicarb if you have a TCA overdose or similar. And obviously trauma, hopefully we'll recognize the cause of PEA. So the goal is to not be too academic in those situations and just try for the best because we have no idea what the cause is and treat all possible options immediately. So optimizing post-resuscitation should be done. Cool therapeutic hypothermia patients at 36 degrees Celsius. Early VFib arrest with ROSC should be received early PCI. The awake arrest patients should receive immediate PCI as well. Cardiac arrest patients in a coma should be continued with therapeutic hypothermia and PCI on awakening. And PCI does improve survival to hospital discharge and cerebral performance in patients with or without ST elevation. So how do we look at arrest and measure cardiac arrest data? I think this is the hardest thing to do because people don't measure it because it doesn't really look good. So we standardize the way we evaluate data is using the Utstein Criteria. What it does, it contributed to a greater understanding of the elements of resuscitation that facilitated a progress towards a consistent international consensus of science. So Utstein Criteria is this. It's a witnessed cardiac arrest, presumed cardiac origin, and the initial presenting rhythm was VFib or VTAC. Now the 2014 AHA National Cardiac Arrest data is as follows. 2013, 2012 data, bystander CPR is being done only 40% of the time. Survival rates are Pretty dismal, 9.5%. Actually dropped from 2012 to 13. And if you look at the in-hospital results, they're significantly higher than out-of-hospital results, but they have a lot more equipment and utilities available that's not present out-of-hospital. Now, I used to be the director of Lake EMS, and we did a change too. We switched from the regular 32 to a hands-on, compression-only, early non-rebreather nasal cannula, and we compared the results. If you look at the national average, cardiac arrest results were 19% overall ROSC rates, PEA was 5%, VFibs 21, Utstein was 22, and survival of discharge was 8%. In our fiscal year of 2012, we had a 40% ROSC rate. The PEA ROSC rate was 31, VFib was 60, Utstein was 68, survival discharge was 26%. When we switched in 2012 to 13 to hands-on compression only, it went up to 41 for total cardiac arrest ROSC rates. PEA and asystole was 31%, VFib ROSC rates was 68, Utstein was 71, and survival discharge was 29. We had 13 double sequential defibrillations during that year, 6 out of 13 ROS with 46% success. Of those 6, 4 went home neurologically intact. So let's look at Polk County data. We've had this for, things were basically the same for 2013 and 14, significantly more cardiac arrest. ROSC rates were 26 to 28. VFib ROSC rates were 46. The Utstein survival of discharge rates have gone up in the last year. It went from 53 to 56. The most pleasing thing, too, is the pediatric ROSC rates. When we looked at our data last year, 2 out of 18 were ROSCs, of which 0 survived the discharge. This year, we kind of adapted the Dr. Antebi method of you work them on scene, 2 minutes of good CPR, early epi, early airway management, and we're very fortunate that we've got 33% ROSC in pediatrics, but the survival of discharge is 71%. So it's a philosophical change of how we approach patients from a pediatric arrest standpoint, and if we, just by making simple changes, not necessarily using everything because we didn't have the equipment, but using that philosophical attempt, you can see what a significant difference in outcomes can occur in the initial treatment of pediatric arrests. So in summary, when you want to have a good system, you need to integrate with dispatch so they can administer CPR with bystanders on scene immediately to those patients who have fallen. All VFib, VTAC patients with ROS should have immediate PCI and therapeutic hypothermia. You want to have EMS to PCI under 120 minutes. If you can grade under 90 minutes, that's great. Realize with cardiac arrest care, airways of secondary importance. In cardiac arrest, it's more important that you do continuous chest compressions. Passive O2 till saturation drops less than 70%. And at that point, I-gel for O2 saturation. You want to have optimal compression rates of 120 per minute, 2-inch depth consistently. Minimize time off your chest with a CPR fraction of 80 to 90%. Minimize perishock and post-shock pauses. And early defibrillation and epinephrine will give you ways to be most successful in getting resuscitation outcomes in cardiac arrest. So with that, I'm done with my presentation, and if anybody has any questions.